Now moving on to our third section, that is the acromioclavicular joint injuries. It is one of the very important joint and one of those joints in which sometimes there's a lot of confusion whether to go for operative or non-operative approach. We'll be briefly discussing the pathological anatomy and its classification, its imaging, treatment, and complications. So what is the acromioclavicular joint? It's a joint which is formed by the acromion process of the scapula and the clavicle. If you see it over here, there is actually the thickening of the capsule around the acromioclavicular joint, which is most common on the superiorly and posterior aspect actually. And this clavicle is attached to the acromioclavicular through the coracoclavicular ligaments, that is the trapezoid and conoid. The mechanism of injury is actually fall on the shoulder with the arm abducted. This is as commonly usually associated with the clavicle fractures as well. There is strain anterior of acromioclavicular ligaments, that is the two ligaments which is called as which form the joints of the acromioclavicular part. Upward subluxation of the clavicle may occur, and that is why, because these are the coracoclavicular ligaments which are holding the clavicle, or once they get ruptured, this may result in the clavicle moving upward. Coracoclavicular may be both be torn, or one of them may be torn as well, and this may result in a complete dislocation of the or displacement of the clavicle. Now, depending upon what is the kind of injury and where the displacement or how much displacement has occurred, this is how we have classified acromioclavicular joints actually. Coming to the classification, there are basically 6 types. Type 1 is an acute sprain of acromioclavicular ligament in which the coracoclavicular ligaments are intact and there is an undisplaced, basically the sprain of acromioclavicular joint. In type 2, there is acromioclavicular ligaments are torn, joint is subluxed, which is slightly elevation of the scapula. This usually almost 25% elevation of the scapula. In type 3, it could be from 25 to 100%. Why? Because acromioclavicular and coracoclavicular ligaments are torn and joint is actually dislocated or completely displaced. Now type 3 is further subdivided into 3A and 3B and form some books divided depending upon the stability of the joint. If there is vertical instability but horizontal stability, that is anterior posterior stability is there but only upward and downward instability is there, this is 3A. But in case of 3B, the acromioclavicular and coracoclavicular ligaments have injured so much that there is horizontally as well as vertical instability. Coming to the type 4 injury, type 4 is actually in which the clavicle is displaced posteriorly. Type 5 is in which this acromioclavicular and coracoclavicular ligaments injury, but the clavicle is displaced inferiorly or beneath the coracoid process is actually 6, and in type 5 it's displaced upwards. So that is how, if it is more than 100% displacement, then you need to classify it accordingly. And depending upon the classification, then there is actually the treatment modalities. Usually for 4, 5, and 6, we have to go for operative fixation. So it's actually very easy. For 1 and 2, most of the time it's undisplaced. For 3, it is actually where we have to decide whether we have to keep it conservatively or go for surgery. In case if it's type 3 injury and usually it's athletes or laborers, then probably we have to go for operative fixation. Now coming to the x-rays. X-rays, the first and foremost is actually AP view, useful view in the anterior posterior cephalic tilt view. Another option could be axillary view as well. But that will actually tell us how much the subluxation has occurred of the humeral head or not. Then are the stress views. Stress views is actually the patient is advised to hold at least almost 5 pounds of weight in both hands and to get an AP view while holding these weight in his or her hand. As a result, if it's a type 2 injury, is partially displaced, but there is complete tearing of the coracoclavicular ligaments. When the stress would be applied, this clavicle, this scapula and humerus will go down, and clavicle, as there's completely torn, so would go up. So this is the classical example, actually stress views. This is to distinguish between type 2 and type 3 injuries. And why it is important? Because type 2 is usually treated conservatively, and type 3, depending upon whether it's a laborer or in athletes, it has to be fixed. Now coming to the treatment, usually the sling until the pain subsides, that is for most of the type 1, 2 and 3 injuries. But in type 3 injuries, sometimes we have to go for operative as well. That is conservatively means sling and shoulder exercises. Operative repair is for all type 4, 5 and 6 injuries, and in all those type 3 injuries in which the patient is young, heavy manual laborer or an athlete, then we probably have to go for operative repair. Operative repair means acute reduction. It could be transferring the existing ligaments or repair of the coracoid ligaments or using of the free graft in form of autologous grafts as well. Now, there's a multiple procedures which can be done. There's a femoral technique, there's Weaver done procedure, a modified Weaver done procedure. There's a Boswell screw as well. We have just explained the most commonly done is the most Weaver done procedure. That is, the sternus lifting movements are avoided. Arthroscopic surgery is done, and modified Weaver done procedure is done arthroscopically. This is, if you see the diagram, the lateral end of the clavicle is resected. Coracoid ligaments are repaired by the endobuttons, and then there is actually a transverse of the coracoid ligaments as well, so that the clavicle remains at the normal position. Instead, it's being displaced upwards. Then the attachment is done through the transosseous sutures. This is a classical example to keep acromioclavicular joint reconstruction as an option. And reconstruction can be done by multiple other methods in the form of femoral technique, Boswell screw as well, but they are open methods. And but reconstruction is indicated when it's type 3 injuries and the patient is either a young manual laborer or a young athlete, and then type 4, 5 or 6 type of injuries. Now coming to the complications. Complications could be rotator cuff problems, which may eventually build up over the time. This could be resulting in unreduced dislocation or subluxed humeral head. There could be ossification of the ligaments, which would hamper the movement. This could lead to secondary osteoarthritis, as there may be associated with acromioclavicular arthritis or even the shoulder arthritis as well. In this section, we have briefly gone through what are the different signs, symptoms of acromioclavicular joint disruption and how to manage its complications. Briefly speaking, there are 6 different types of acromioclavicular joint disruptions. Type 1 is sprain, type 2 is complete tear, but there is partial displacement of the clavicle. The problem is until type 3A, usually the acromioclavicular joint is disrupted, but coracoid ligaments remain intact. In type 4, the clavicle goes behind or posteriorly. In type 5, it goes superiorly. In type 6, it goes inferiorly. The classification is done so that we can classify the injury and address the treatment. For all type 1 and 2 and most of the type 3 injuries, usually the conservative treatment is done. That is in form of a sling for a few weeks and then shoulder exercises and exercise program for muscles. But for all 4, 5 and 6 injuries, usually we have to go for operative procedures. In type 3, if it's a young person, if it's an athlete as a manual laborer, then probably we'll have to go for operative early. And then what are the different procedures for the acromioclavicular joint? There are different techniques. This could be in form of open reduction, this could be in form of autograft, this could be modified Weaver done procedure, femoral technique, Boswell screw. But usually the most commonly done is the modified Weaver done, in which the lateral clavicle is resected. This graft is placed for the coracoid ligament so that they can hold that clavicle in its place. Thank you very much. Keep watching sqadia.com.